Hello, and thank you for joining us for today's virtual education program at Cancer Support Community South Bay. I'm Rebecca, the program manager, and I welcome you to this workshop titled, Frankly Speaking About Cancer, Bladder Cancer. Before we begin, if this is your first time joining us, CSC South Bay's mission is to uplift and strengthen people impacted by cancer by providing support, fostering compassionate communities, and breaking down barriers to care. Our vision is that everyone impacted by cancer receives the support they want and need throughout their experience. We serve the South Bay, Long Beach, and Orange County area all at no cost. Our program includes support groups, networking groups, healthy lifestyle classes, social activities, and educational programs like this workshop. Educational programs are open to all. If you'd like to hear more about our services or join our community, please visit our website at cscsouthbay.org. Before I introduce today's speaker, we ask you to keep your microphone muted to eliminate any distracting background noise. Please feel free to enter any general questions into the chat function found at the bottom of the Zoom window, and we can get to them at the end of the presentation. Without further ado, I'd like to introduce our workshop speaker. Dr. Lawrence Flechner is a leading South Bay urologic surgeon with expertise in robotic and minimally invasive surgery and with extensive experience in treating patients all with urologic cancers. He is also on the professional advisory board for us here at CSC South Bay. So thank you so much, Dr. Flechner, for being here with us today.
Thank you very much, Rebecca. Thank you, Cancer Support Community, for having me and inviting me. It has been a true honor and privilege to be part of the advisory board, and I look forward to continuing that relationship and working with patients in this setting and in the office setting as well. So I was asked to speak today about bladder cancer, really to patients, not, kind of taking off the white coat, but talking a little bit about more candidly about it and going through what the process is on many different levels. And so I'll be happy to answer questions at the end. So I'll get started. This is me as I was, thank you for the introduction. I do work in Torrance, and my offices are across the street from Torrance Memorial. And I have no disclosures I have no affiliations to disclose. This is, again, an introduction and kind of a shout out to the cancer support community, and thank you for putting this on. These slides were, before I get into that, the agenda today is into 4 parts. It's number 1, we're going to start with discussing empowering patients through knowledge, through information about what is bladder cancer and what's involved. Strengthening patients by ways that they can be active in this process. Having patients be sustained by community. And the 4th item on the agenda is discussing life after the diagnosis. These slides were put together not by me, but by this gentleman, Dr. Daniel Geinesman. He's an oncologist, a medical oncologist at Fox Chase in Philadelphia. So thank you to him. Starting with our first item on the agenda, empowering through knowledge. Starting with the understanding bladder cancer. Most of the time, bladder cancer is picked up with identifying some blood in the urine that you go see a urologist like myself. Sometimes it's incidentally found on imaging or other manners. But as I said, usually it's identified by some problem like blood in the urine or urinary symptoms meeting with the urologist. It occurs, this is the some general anatomy here. It occurs when the cells in the bladder grow and divide uncontrollably. And and there are many reasons why bladder cancer starts. Smoking is a risk factor. There are some other risk factors that we don't need to get into today, but whatever it is, it's spurring on the cell growth. And usually it starts in the lining of the bladder you see on the right-hand side, the inner lining, that blue. It's called the urothelium. So in fact, all bladder cancers are really part of something called urothelial cancer, which can arise in the ureters, where the kidney collecting system is. It's the same type of cell, and in the urethra. All of those are urothelial cancer, but 90% of all urothelial cancers are bladder. Therefore, bladder cancer is is a generic term. And when cancer cells grow, they form tumors, so some terms to know. How we treat and these are treatment terms. Chemotherapy is they're drugs that really attack all rapidly dividing cells, including cancer cells. So they may attack hair cells or other cells as well. But chemotherapy is a form of cancer treatment. Targeted therapy are types of therapies that, as it implies, targets the cancer cells themselves. Radiation therapy is the use of radiation to target the bladder cancer cells. Immunotherapy is a form of treatment where some drugs activate the immune system of the person to fight cancer cells. Maintenance therapy is meant to be, it's even after treatment, there are additional perennial treatments that are recommended that either prevent recurrence or maintain a certain status of the cancer. Trimodal therapy really includes a surgical, usually a chemotherapy, and a radiation. So that's a term, trimodal therapy. Clinical trials are when standard guideline-based therapies are either not indicated or exhausted. There are clinical trials of new drugs that come out, and sometimes in this space of bladder cancer, they become relevant. Cystectomy is what a urologist does. A cystectomy is the removal of the entire bladder, and often in men, prostate attached to it. And that's done for bladder cancer. It's rarely done for other reasons, but a cystectomy is a removal of the bladder. What has to be done is, at that point, is the redirection of the urine in another form. And the redirection, one type of redirection is when someone uses a piece of intestine and connects the tubes or the ureters that drain the urine from the kidneys, and it goes outside of the abdomen into what's called a urostomy. And so that's how someone drains or diverts the urine. Chemoradiation is the combination of chemo. It's what we call a bladder sparing type of treatment, when someone's, let's say, going to not do a cystectomy. And chemoradiation is a combined chemotherapy with radiation after an initial resection with surgery, but not a complete removal of the bladder. Okay, diving in, knowing your healthcare team. I already alluded to that a little bit. There are medical oncologists and there are radiation oncologists. You'll usually first meet a urologist like myself, or the urologic oncologist, who may identify and diagnose and do the initial superficial, the initial resections to find this. Medical and radiation oncologists get involved when there's more advanced treatments beyond what the urologist's scope is. There's obviously the nurses and the teams with these specialties, with oncology, urology, and wound care, and that get involved, especially after surgery with cystectomy and urostomies. How do you manage that urinary diversion? In different levels of bladder cancer, we have palliative care specialists help. And those are specialists that focus primarily on relieving pain and maximizing quality of life. There's physical therapists who are involved in all aspects once someone's had either surgical or chemo or other non-surgical treatments that take its toll on the body, and the patients need to adapt. And so physical therapy has been used on many in many ways. Diet can change, or the body can change if the bladder is removed or in the process of getting chemotherapy and radiation. And sometimes dietitians play a major role. Social workers help patients navigate this whole process outside of the clinic. And, there are other people involved, patient navigators, obviously financial navigators because there are high costs to the care, both medical and non-medical care for bladder cancer. Quick check-in. Why is cancer staging necessary? I can't see my whole. Yes. Staging, let me back up. Grade is when a urologist does an initial resection and identifies, is it an aggressive or non-aggressive cancer? There are actually, the majority of bladder cancers are can be non-aggressive. We're not really talking about that today. The grade is going to be considered high grade or aggressive, which means having a potential to spread. But there are other low-grade bladder cancers that only hit the lining and always stay there. So it becomes a superficial thing to manage. But really, in the scope of this discussion, the grade is high grade assumed. The stage, grade and stage, the stage is the extent of the cancer as it goes into the body. And we'll go into that a little bit in detail. Can the stage of the bladder cancer change over time? Yes. If left alone, bladder cancer will progress and become a different stage. It can go from the lining to the muscle and beyond. That's obviously something we want to prevent. What diagnostic tests did you perform to help you understand the staging? The primary, now I mentioned the resection, the grade. Now for staging, it's really about CT scans. Now, if we're worried about bladder cancer outside of the bladder, we get PET scans. But the lining and the stage, whether it's stage, I'll go into this in a second, 0, 1, or 2, the PET scan the CT scan is going to be good. That's just it has some contrast when we look at the tissues. A PET scan is a CT scan with you get an IV infusion of an agent that lights up highly metabolic cells, so that will help us see in the whole body if there's something elsewhere of concern. Finally, does this stage of cancer impact treatment options? Of course it does, and we'll go into that in some detail now. Understanding bladder cancer staging. Now, as I mentioned earlier, the majority of bladder cancers that we identify are non-muscle invasive, about 2/3 to 70%. Stage 0 is just when it's in the lining of this. If you remember that anatomy, that picture I showed, it's just the lining, or the urothelium as we call it. And stage 0 is treated by surgical resection, shaving off the cancer. They can recur. You have to make sure that they don't. And you do surveillance protocols by looking inside with those cameras called cystoscopies. Stage 1 is when the tumor penetrates the lining but goes into this connective tissue. That's still potentially superficial and managed, as I mentioned, with stage 0. And like in here, it's managed with what we call transurethral resection of bladder tumor, TURBT. Sometimes, and so you see here a scope is going into the urethra of this female, and there's a little tumor, and it has electrocautery, and we scrape it out and remove it and send that specimen to the pathologist. And then we have to monitor periodically. If it's superficial, which I'll specifically stage 0, stage 1, either in the lining or just in the connective tissue behind the lining that's treated as such. There's chemotherapy agents we can give in the bladder. There's something called BCG. It's the Bacillus calmette-guerin. It's the TB vaccine. This is always one of the most interesting, weird, incidental findings of time is even today, after all of our molecular knowledge, what we found out decades ago was that people who were getting the live attenuated TB vaccine, their bladder tumors were going away. So we found that the live attenuated TB vaccine, or BCG, if you give it into the bladder, it can prevent recurrence. It's done so by enhancing the immune system's ability to identify and fight bladder cancer cells. Now, when we switch, so the treatment goal is, I don't always shy away from using the term cure. I like no evidence of disease or indefinite remission. Cure is a bit of a concept that there's no more cells there, no more cancer, and that's obviously our goal. But it's kind of like, is perfect a thing? It's an aspiration, but no evidence of disease. It gives us the reason why we continue to have surveillance. Therefore, and that's the goal of non-invasive surgery, bladder cancer. Now, if we're shifting gears and talking, then we go into muscle invasive bladder cancer. This is really where treatments become much more involved. Stage 2 implies the invasion of cancer cells into the muscle. Now, the bladder is a muscle. So that lining goes from the inner lining, the urothelium, the connective tissue, and then muscle. Once it's hit muscle, that's called stage 2. And stage 3 is when it's penetrating even the muscle and going into the peri-bladder fat tissue and other organs and even lymph nodes. This is where surgery alone, the scraping, is not sufficient. And where if you try to do that scraping for the non-invasive, it's going to progress and you're going to lose. You're not going to get it. It's not going to be an effective treatment. So that's why we'll be talking about the medical oncology involvement. When we talk about chemotherapy and radiation and other targeted therapies, it's really involving muscle invasive, or in this case, stage 4 would be metastatic or locally advanced. Stage 4 is when the bladder cancer is in other organs, adjacent or non-adjacent or distant. So that's why staging is so important. Treatment options, I alluded to a little bit. If it's muscle invasive stage 2 or even extensive stage 1, we talk about cystectomy. Cystectomy is a very major surgery, and it's what I had mentioned, removal of the entire bladder and the prostate in men as well, and then redirecting or diverting the urine in different ways. For muscle invasive stage 2, we also, even with surgery, we give some chemotherapy, some that general types of chemical drugs that kill all rapidly dividing cells. So you get that part of stage 2 muscle invasive with a cystectomy as we call it neoadjuvant, or adjuvant is alongside of the short course. If someone did not do a cystectomy, or what was called bladder sparing or bladder preserving treatment, there's chemotherapy, immunotherapy, and targeted therapy, which is in the form of other types of drugs to kill the cancer, and radiation, which wasn't put here. But for muscle invasive, we would use radiation as well. The goal of treatment, the treatment goal of muscle invasive and metastatic cancer is to slow the spread of the cancer or to limit its growth. Now, people with stage 2, even stage 3, I mean, technically it could be completely cured with surgery and other treatment, radiation. And remember that no evidence of disease, and that word cure is a little bit slippery, but it becomes something where we put patients on a continuous surveillance because the risk of recurrence comes high. And so now for metastatic bladder cancer, it's really about limiting tumor growth. And of course, it's always our major goal, extending life, while at the same time optimizing a patient's quality of life and symptom control. As these treatments do bear a lot are very difficult to go through many times. Maintenance therapy is now in superficial disease. I mean, the idea is it's lowering the risk of recurrence. And I mentioned the BCG, and there are other new types now, but that's for preventing it from coming back. And in metastatic or muscle invasive, it's really stopping it in its tracks for as long and effective as we can. Can staging and treatment options change over time? They sure can if we don't do anything about them. But if we do a full treatment, they can be, you can, the goal is getting with no evidence of recurrence and a stable disease, and that's our goal. Now, this is a lot to hear, and there's so much to say. I'm going to shift now to the second item of the agenda, patients being strengthened by action. Now, a lot of this, I can imagine patients will feel powerless and they don't have, it's hard, it's overwhelming in terms of the knowledge, in terms of where a person fits in all this. And so it's very common to be feeling out of control. And so these are some ways of talking about how a patient can maintain control through this process. It's the basics. It's, preparing, it's writing things down, because there's so much that's going to go through, half of it going in one ear out the other. Doctors speak quickly. They're always in a hurry. As much as we don't want that, these pressures for us to be in a hurry all the time, but it's how to prepare for appointments. It's trying to have as much information as you can during it, and coming with someone for having a caregiver with you. I always ask when I'm dealing with cancer, especially cancer patients, please bring in a significant other, anyone, a trusted partner. 2 sets of ears or more is always good. For both you and that person to be taking notes and emphasizing. And sometimes a patient may be feeling like a punching bag with all this information, and the caregiver can, remind the patient something that they were worried about, they wanted to bring up with the physician, or to help guide what they think is, as an advocate, what the priorities of the patient are as well. It's important to be aware to kind of sit and write down what are your goals and your values as a patient and in life, and to be very zoom in and zoom out, from the physical health and well-being standpoint. What's the most important for you to be able to do in life? Just to have these sort of questions that help to define the parameters for you. Every patient's going to be different. For family and social relationships, what's going on in the lives of others that's important to you? From a work relationship or a school relationship, do you want to? What's your relationship with work in the setting of this new diagnosis? Do you want to continue working? Can you adjust your schedule and your responsibilities as situations may change and your priorities may change in this? Do you want to explore retirement or disability, different forms of work? Community involvement here. Are you getting the support you need from your community? Are you able to stay active in your community? All these are of vital importance for you to know. The doctor, it's going to be a little bit out of their purview, but it'll help you define the parameters that you can approach this, both in the doctor's office, but in all the other capacities we had mentioned a little bit earlier, and whatever other priorities you have that are important to you. I always encourage second opinions. This isn't about me and the doctor saying, I think I know what's best and here you are. This is always about shared decision. This is my role as a physician, is to get as much information as I can to help the patients make the best decisions for themselves and their loved ones. And that's the number one. If they choose different types of treatments, it's not about It's about meeting the needs of the patient. And a second opinion sometimes helps, just with another voice of opinion, helping ground you. Even if you have a great rapport with your primary urologist or medical oncologist, if there's any questions, sometimes it just helps you know that you're on the right track. Obviously, you need to be on having a very good rapport with whoever's guiding you through this, because it requires a lot of trust on your end. And I appreciate that and think about that every time I'm with a patient, especially with cancer. Clinical trials, there's often clinical, new tests and new treatments. It's not just it's for all stages of cancer. So you're always right to ask about clinical trials, whether, you have to know in that setting, what are the guidelines and what quote unquote should be done, or what options do you have from a standard guideline standpoint versus what new things are out there. And a new thing needs to show why it's being asked and why it thinks it may be quote unquote better, and then what are the pros and cons of that. And they can be either in treatments or managing side effects. It can help you understand what the nature of this cancer is. And so ask about them. Are they available? What are the potential benefits? And are you eligible, and how would you get that information, and how could you enroll if that's something that is appropriate, that you and your physician would find to be such. This is a really important item as well. Being sustained by your community. You're not in this alone, and you have a lot of even though I'm sure it may feel that way, but you have many resources available to you going through these challenges. As I had mentioned, it's very common to feel a loss of control, isolated and alone in what you're going through, even among your family, or definitely among the community. And we all live with uncertainty, but in the setting of bladder cancer, it just adds that layer of anxiety that I think it helps to know that you're not alone, and that to know who, and to identify who's out there, and to ask who can help you, and what are the resources. And that's a little bit what Nancy's going to speak about with cancer support community at the end. Last item on my agenda: life after the diagnosis. Life changes a lot now, especially when there's muscle invasive or metastatic bladder cancer. Life, hopefully, as I mentioned before, will go on and the goal is maximizing or minimizing side effects of any treatments, and maximizing quality of life, and getting as much back to your pre-diagnosis situation as can be. The treatments, unfortunately, I'm going to be very general about this. There's a lot of side effects that people can have. It's not a guarantee, but in some go through it a little bit differently than others. But the ones as follows are very common: nausea, neuropathies or sensory changes, fatigue, skin changes, rashes, hair loss. We call it something chemo brain fog, where you just don't feel like you have the mental acuity. Urinary incontinence and pain in the urinary system, whether you're having a cystectomy or you're having chemotherapy, urinary situations. A lot of my practice, a lot of time goes into talking about sexual dysfunction associated with these treatments, which is we take as a very big deal, obviously, as its importance with quality of life. And blood in the urine is hematuria. And sorry, one second. Weight loss can be affected by all of these treatments as well. Loss of appetite, pain. these are these things that for us to prioritize, and there's short term and then there's long term effects, and the more advanced treatments can have long term effects. There is a registry called the Cancer Experience Registry. And according to the Cancer Experience Registry, 56% of patients were moderate to severely concerned about eating and nutrition, and 51% about exercising and being physically active after the diagnosis. Eating well is a treatment. That's an important part of the treatment one treatment aspect. That's where you can enhance your energy, build strength, nutrients, protect your bones, prevent illness. Does diet, are there anti-cancer effects on diet? I mean, that becomes a little bit of a debatable thing. I think, epidemiologically, I think there's something to that. But when we're talking about going through these treatments, I think just eating well is always going to help in the treatment process. And then movement and exercise, building strength, improving balance, improving muscle mass, and the psychosomatic benefits of that are very important. Physical therapy is extremely important in maintaining strength through any of these treatments. Now, there's a whole world of pelvic floor physical therapy that helps with in the post-operative setting as well, bladder training, whether you have new bladders or new forms of urinary diversion, bladder training or urostomy care, these kinds of things. It's also crucial in helping you. Doctors, I always say, we talk about diagnoses and the condition and their treatments. And then when you leave the office, there's so much more that can be done from a physical standpoint. And I think physical therapy picks up where doctors leave off, and it becomes a crucial part, in my opinion. According to the CER, 42% of cancer patients were concerned about moving and walking after procedure, or after treatment, whether it's from just getting up and moving around or climbing stairs, lifting, exercising, etc. I mentioned the urinary diversion, which is a urostomy or a neobladder. Just for this is a little bit more definition. Urinary diversion is when the bladder's removed, you hook up those tubes, the ureters, into it has to be a new outlet. And classically, we use a piece of intestine or ileum, the end of the intestine. And that is fashioned where the ureters are connected to it as a kind of a hollow cylindrical tube, and one end is closed off. The urine diverts in there, and then the other end goes out onto the lower abdomen, usually the right lower abdomen. And if it's just draining into a bag, it's called an incontinent diversion or urostomy. A continent diversion is some form where, and there are many types, not to get into the technical aspects of it, but where there's some device where it's not hooked to a bag, but it could be hooked to a tiny new channel that you can catheterize. And a neobladder is a continent diversion where the intestine is fashioned into a ball, a spherical ball, and then reconnected to the penile urethra, or in a woman, the vaginal urethra. And so a man or a woman urinates through the urethra again. There's many pros and cons about each one, whether it's possible anatomically or is appropriate based on the staging and all these, a lot of factors, but those are the definitions for those terms, and those need help. Those need but there's urostomy care, and there's care for people afterwards who manage that. This is obviously, as I was just going into, these are big changes in the body, either male or female, whether you had the surgery or there's chemotherapy and radiation as well. and it's important to try, from the health provider aspect, is to help you find to maximize both quality of life, minimal symptoms, and enhance and making sure, we try to help you with the body image as these things change things as much as we can. And I alluded to it before. A lot of discussion is surrounding sexuality and intimacy, as this does impact, private parts of our anatomy, and something that we only share with in terms of in settings of intimacy. And so, how does that get? How can we help patients go through that, both with patients and their partners as well, is a great importance and something to be addressed. And how, as I was saying, how it impacts caregivers as well. All of this is I think just reminding of being in this treatment process after a diagnosis, being aware of how you're feeling and listening to yourself, and being present with yourself as much as possible, what's going to get you through this, and how you're going to have to adapt as best as you can. And there are resources to help you. The CER, we're back to this Cancer Experience Registry. They said that 53% are moderately to severely concerned with worrying about the future and what lies ahead, about the risk of clinically significant levels, or 49% have clinically significant levels of anxiety, and 38% are at risk or clinically significant levels of depression. Well, here, what are the options? It's being here with the cancer support group, with the cancer support community, working with therapists, being open and honest, as I was saying earlier, being open and honest with yourself and with family and loved ones. This is always an important thing that doctors, we're talking about health and we're talking about quality of life. One big factor is this costs a lot, and we got to understand this. There can be a big financial burden on patients. And according to the CER, 44% of patients had health insurance or had worries about the coverage of this. And I think that's a crucial thing to be open and talking about, especially in the cancer support community settings. And this is where doctors' offices, we fall short. We're busy trying to manage some of these, the disease itself. But this is something where I think other resources can really help. Cancer treatment and follow-up appointments can take place over months and years, as I was alluding to, and there's surveillance and maintenance, and it adds up. And asking for help and finding what those resources are going to be crucial. When bladder cancer recurs or progresses, we talked about the aspiration for cure, or without any evidence of disease. We talked about optimizing the control, minimizing its growth, but when it turns the other way, this can be very difficult. Of course, 56% of respondents are moderately to severely concerned with cancer progressing. What can you do? Learning the signs can be a little difficult, and that's sometimes we don't know what the signs are. We're not feeling it. I think the most important thing to do is going to be having a good maintenance plan with your oncologist, and that's usually going to be in the form of blood tests and of various types and imaging. Now, CT scans become important, and following that care plan is going to be important. And then, of course, planning ahead. the imaging tests. That surely leads to a lot of anxiety during the appointments you're going to have to go over new surveillance CT scans and things like that. Care plans. Once you've been treated, it's important for you, I think, just moving forward to know what that summary of treatment was and to have it in a relatively concise way written out. And the doctors have their charting notes, but for you to know what that was and to know what the follow-up is. Where do we go from here, obviously? What are the screening, as I had mentioned, everyone's going to be a little different, but having that clearly in mind, what is your follow-up management plan? And are there other specialists that need to be involved? That can be the case. Palliative care is a very important, it's sort of a statement. It's in the way I look at it. Palliative care focuses on providing relief and minimizing pain from what you're going through. And the goal is really focused on the aspect of care that's optimizing your quality of life. It doesn't mean that you're choosing, it doesn't have to be contradictory to the treatments you're getting. It just needs to be, it's a way of addressing and prioritizing your care, your quality of life. Now, caring for caregivers, I'm going to, I thank you for your attention. I'm here, but I'm going to turn it over to Nancy, who with the cancer support community, to give you a little bit more on this. Thank you.
Yeah, thanks so much, Dr. Flechner, for presenting those last slides. And I know at the end you will be here to answer questions. And I know I see a few in the chat box, and I'm going to encourage people to continue to put their questions in the chat box. For those of you who don't know me, I'm Dr. Nancy Lomibao. I'm the Chief Clinical Officer and Program Director at Cancer Support Community South Bay. And I want to just talk with you a little bit more about caregiving as well as the services that we offer from CSC South Bay. So I want to acknowledge too that some of you may be caregivers who've joined this workshop. And this is the year of the caregiver. So we're going to discuss a little bit about caring for caregivers.
Oh.
So the support for caregivers really is about taking care of yourself. There's a lot of focus on the cancer patient, but it's so important that you find your own support and that, looking and asking for help is so important. We have that here at CSC. Just to break down some of the caregivers' tasks and information that we found through our cancer experience registry, the data showed that 79% of caregivers provided emotional support, and 91% accompanied their loved ones to medical appointments. 79% help with decision-making. 82% of caregivers provided transportation. 77% coordinated medical care. And 41% help manage finances. So if you look at that, those are a lot of tasks that are high in the percentages of caregivers for bladder cancer. So it's so important to take care of yourself, to prevent burnout, setting limits and boundaries about what you can and cannot do. Important to pace yourself because cancer treatment can be a long haul. And when you're supporting someone, you really need to pace yourself and control your stress as well. Your needs are just as important as the cancer patient's needs. So the cancer patient can't do all the things they need to do without your support. So you need to be healthy and have a strong mindset. So make your needs a priority. Be direct, especially when talking with healthcare providers, and delegating different tasks to family members or friends. If they want to come over and do the laundry or do some grocery shopping for you, take your loved one to an appointment, and just those things can be so helpful for your own mental health. Of course, keeping tasks realistic and retaining flexibility. So these are some of the ways that you can find support. Caregiver support groups. We have 2 here at Cancer Support Community South Bay. They're on Tuesday and Thursday evenings, and they're offered via Zoom. We also have individual counseling where we have counselors here available for 6 to 10 sessions of individual counseling for the caregiver to support your needs. And then also encouraging you to look at your own communities and perhaps some religious leaders or your faith destination. Also recognizing that some of you may be caring from a distance. So it's critical to understand the situation of what's going on. You might feel a little detached. So creating a list of important contacts for emergencies, not rushing any types of decisions or pressuring the cancer patient from a distance, and then to listen and seek help when you need it. So again, with our support groups and individual counseling, we support people who are caring from a distance. So they're eligible for all of our caregiving services. Now I want to talk a little bit about CSC and our community resources that we have available. These are some links that are available through our headquarters website that touch on coping with mental health, specific to caregivers, clinical trials, becoming an advocate, cancer treatment, and then we also have a specific link for bladder cancer. We have a cancer support helpline that if you have somebody, a loved one, perhaps in another state, and you want to try to find the local resources, this is a nationwide helpline. So the phone number is down there, and they can help mainly during business hours, but certainly you can leave a message if it's after hours, and they'll get back to you and help any of your questions you might have about various topics. So these are some of our direct community resources. You'll see Unio Specialty Care. That is actually where Dr. Flechner is. He's on Tilo Avenue, and that's the name of the specialty care for the urology. Dr. Flechner is also associated with Torrance Memorial. And so there's a link there to Dr. Flechner.
Yeah, just a few, I'll chime in
Go
just
ahead,
with
yes, please.
on this. I thank you so much, Nancy. I think the priority is going to be, once there's a diagnosis, is finding a place wherever you're going to be treated. It's a multidisciplinary, multi-specialty place. So where I work at Torrance Memorial, there are associated medical oncologists and radiation oncologists I work with to manage all aspects, and the associated nursing teams as well that we had said earlier. So that's local in the South Bay. Of course, UCLA and I'm not leaving anyone out. The big players in the LA area, UCLA, Cedars, University of Southern California, USC, and City of Hope, and all those entities will be giving levels of multi-specialty care that are important for this kind of disease process. Torrance Memorial is affiliated with Cedars. So it's sort of in that link, but those are these are the big players in Southern California, as you probably know. Lastly, the Bladder Cancer Advocacy Network is a nice resource for patients on the bottom left. And okay, I'll turn it back to you.
Yeah, not a problem. So this next resource that we have available is called My Lifeline. It's available in both English and Spanish. It's a place to find support, hope, to exchange your ideas and stories. It's where you can connect on to the internet, and you have your own private community website where you can interact. You can have your own blog. You can document your cancer journey. It also has a feature where you can assign care coordinators to help arrange a calendar that you can then share with others and put on things like need a ride to chemo, need a ride to the surgeon's office, and be able to have your family check in on that and perhaps agree to do one of those tasks. You've heard us mention several times the Cancer Experience Registry, and this is actually a registry that Cancer Support Community oversees and tracks information. It's really based in a research study so that we can gather all the information, the patient voices, and be able to then share that with all of you, but also to look for grants for more information and educational workshops just like this one. So we do have a grassroots network, and we have people who will go to Capitol Hill and lobby and fight for cancer patients' rights, bills, and laws. So you can join that grassroots network and be able to have your voice heard along with others. So if you want to become an advocate in that capacity, there's a link there for Become an Advocate. Okay, and so before we get to the questions and answers, I just want to mention that this presentation is funded through a grant, and part of the grant requires that we have a survey answered. So you will see show up on your screen a QR code, and if you use your phone and click on that, it'll take you to the brief survey. So I would love if all of you could do that. But in the meantime, we are going to ask Dr. Flechner some questions. So I'm going to read the first one out to you, Dr. Flechner, and then hopefully you'll be able to answer these. So we have a question here. Could you please tell us about Tecentriq as a treatment for bladder cancer? Thanks.
Tecentriq. I have to confess something. I'm going to do the best I can with answering your questions. And I'm aware that there are going to be some things. So as a urologic oncologist, I'm not involved as much in the administration of chemotherapeutic drugs. That's what a medical oncologist is going to be involved in. I'm not going to be as useful in getting information about efficacy of Tecentriq versus Keytruda and other. So there are other. But I can say a little bit about what it is. I mean, Tecentriq is a drug name, but the real name is acetalizumab, and remember we talked about different types of therapies. This is whether it's targeted, but it's an immunotherapy drug. It's called a PD-L1 blocker, and it's actually it's related to there's a drug called Keytruda, which was one of the earlier ones, and these are drugs that enhance the immune cell's ability to fight the cancer. These drugs have been found to be useful in a whole host of cancers, including lung and liver, and I can go down. So these are these they're enhancing the immune system's ability to fight cancer cells. That what brings it on many fronts. So I don't. So this is one of those, and it's being, whether that's the new one as opposed to Keytruda. These are rapidly changing things. It's not my specialty to know that exactly, but what I will say is classic chemotherapy is now being there are new adjuncts or additions to it, these types of drugs being one of them. And remember, in the treatment goals of whether it's either stage 3 or 4 metastatic bladder cancer, these drugs are showing the effects of slowing that progression. And so, again, I don't have the latest the efficacy effects and comparisons on it, but they're definitely being addressed. Now, you'll have to talk with your medical oncologist. Whether I'm not, I mentioned I know the other common one, Keytruda, but is Tecentriq becoming better? Are there reasons? Is there a clinical trial that has said that? I'm not aware, but that's something to pursue more. Sorry if that's insufficient, but hopefully that gives some insight.
Yeah, thanks, Dr. Flechner. A lot of medications and they're changing fast.
Yes. And I will say, just in a little zoom out commentary about that, this is an exciting time in a number of cancer fronts because of drugs like Tecentriq and Keytruda. These are like given in all cancers. And I don't know anything about lung cancer, but I know it's given in lung and prostate and all. I mean, so there's an explosion of new drugs out there. And unless now I can tell you a lot about the urologic side of things, but for the chemotherapeutic side of things, it's almost it's dizzying for oncologists to medical oncologists to keep on top of. So what's the latest from the urology standpoint? I couldn't tell you, so I apologize, but I hope that gives you a lot of reassurance of what's going on right now with targeted therapies and immunotherapies in bladder cancer and others.
Okay, great. We have a question here about, can you have a recurrence if you had very aggressive CIS and BCG and cystectomy?
If you had carcinoma in situ, which is a high grade but superficial bladder cancer, but with a real potential to invade into the muscle, and if you had a cystectomy, now the recurrence depends on what the final pathology of the cystectomy was. So if they felt that the cancer was contained in the bladder and and there were no margin, we call a positive margin. So if it was a surgically complete resection with the whole bladder removal, which is the goal of the cystectomy, and if that's the case and there was no cancer elsewhere, remember we talked about cure and no evidence of disease, that slippery word cure. I mean, that's a potential for no evidence of future disease. You'll require surveillance. It depends on, now, could there be recurrences? They could exist in the other parts of what we call the urothelium, such as the ureters, where the kidneys are. Now, it's unlikely, but those are possibilities, and the urethra. Now, those are very unlikely, but remember what I said about that word of cure meaning perfect, and just perfect, is that really a thing? But it's a goal, and that's a hopeful no evidence of disease, but it's something that would require its own surveillance with screening tests, screening imaging to follow to confirm there's no recurrence.
Okay. Becca, do you have any questions that went to you directly? Okay, I don't think so. So any last questions that you want to put into the chat box to ask Dr. Flechner?
Nancy, I was just asking if you could show that slide that had the URL resources.
Oh, okay. I think Becca went back to that for a second, but if she can go back again, that would be great.
Thank you. And thank
great.
you for the workshop. It's full of great information.
Yeah, I think that this is one of the ones where we see workshops and information on bladder cancer a lot less than some of the other cancers. So it's so important to cover this topic.
Thank you. Which one
And,
did you want me to show? I'm sorry. Which
It's
one?
the one with all the URLs. It
Oh, of
was the
course.
resources,
Yes.
like 15 resources, I think.
Take a picture.
Thank
Hold on,
you.
I'm getting there.
I can also email that out.
The one in front of
tomorrow
that.
as well.
Oh, in front of this.
Yeah.
I apologize. Give me a second.
No, that's great. Thank you.
I think did I pass it?
Yeah.
Here we go.
There you go. Thank you.
Of course.
I
Got
had
it. Thank you. We
I have a
have a
question.
lot of people, so thank you. We can share more information.
I can also email the resource list out tomorrow as well, so you have the direct links.
Thank you, everybody.
I think someone was going to ask another question, perhaps. I heard a voice.
Yeah, I had 24 lymph nodes cystectomy. This is done 8 years ago, but 9 years ago I had stage 4 ureter cancer, and so my kidney was removed. I was recently diagnosed with that I have an inflamed lymph node in the groin area. Could that be cancer related?
So you had urothelial carcinoma of the right ureter, and you had is that right? You said
With the left ureter.
the left. So you had a nephroureterectomy and a lymph
Yes.
node dissection of 28 lymph nodes, and the pathology looked good. Is that correct? It was negative. Do you know what the stage was?
I had with the ureter cancer, I had stage 4.
What does
But
that
the
mean?
following year,
Was it in the where was it outside of the ureter?
it was in the ureter at the junction of the kidney.
But they removed the kidney too, right?
They removed the kidney. The left kidney, and the ureter.
Yeah, I'm not sure how it's stage 4 is what I'm getting at. Just in terms
They had removed some of the lymph nodes.
and some were positive.
There were some positive
Okay,
with the ureter cancer,
I
but
see.
when they removed the 24 lymph nodes from the bladder cancer, they were not positive. But just recently, I was diagnosed with groin pain and that there are 2 inflamed lymph nodes in
I'm
the
sorry.
groin.
I'm so sorry. Did you also have bladder cancer and the bladder was removed too?
Yes, that was done the
see.
following year.
I understand. Okay, and then so they're watching you closely. So this
Right.
was 8 or 9 years ago.
Right.
And you're saying that there's some inflamed, and so it's been 8 or 9 years. And look, I mean, that's a long run of being without any disease evident, and that's very encouraging and reassuring. If there's something that that may be something that needs to be biopsied. It may be something or nothing. It's really obviously I couldn't. Just from hearing the story, the scenario, the most encouraging thing that you're telling me is the length of time that no one's seen anything. At least that's from my understanding. Sounds like a
Right.
very involved, multiple surgeries and but if it's been 8 or 9 years, that's a long time for something to come back. But it's not impossible. But it's not to say that that's in any way inevitable. It would need anyone who's looking at that, you really need to double down and, get more information. I imagine that PET scans are being involved, and someone may be talking if they see something. Is it potential to buy? I don't know. It has to do with where it is. Is it accessible to biopsy? But these are the kinds of things that come to my mind. But I wouldn't assume something. If there's something even that's borderline questionable, it's something that gets monitored, right? Or, if you can't get a direct answer with a biopsy. But I wouldn't, just in the question that you asked me, stay very hopeful and, hopeful and confident that it isn't, but, do the diligent next steps with whatever's possible with your oncologist, and they'll obviously get to it. But I just don't assume the worst.
Okay. Thank you.
Of course.
Yeah. So Dr. Flechner, another question came in. What percentage of patients have sexual dysfunction with the new robotic surgeries?
Oh, it's a really good question, and I have a really bad answer because it always depends, and everyone hates that, but I think robotic surgery and something that I do a lot of. I think the issue with the issue is not the robotic surgery; it's what the extent, what's being removed, and how are the erectile nerves. And we're talking in men. How are the erectile nerves affected? Remember, it's really the full term is a cystoprostatectomy, because the prostate has a lot of urethral tissue that's removed. At least standard of care, the prostate's removed alongside it, and the erectile nerves are in that field. It should be, for people doing a lot of robotic cystoprostatectomies, they should do and this is also the important thing, is how assuming that a person's erectile function was normal, if we're talking in men, what normal to begin with, there are nerve sparing or preservation ways and methods, and that would be an important thing to talk about with your surgeon. Trying to spare those nerves and minimize their injury as much as possible. It's never 100%, but if everything was perfect before, we're talking hopefully 70%, 80%, something like that. It's not a guarantee because it's still the surgery and it can have an impact. If there's preoperatively no erections, that we're not getting anywhere with that. Now, women is a different story, and I don't know. That's a more challenging thing in terms of because in men we're often talking relevant issue is the erectile nerves for erections. Sexual function is a big broad term. Desire, libido, all these things can be affected. None of them affect in men testosterone. And but these have, sexual function is beyond that alone. That needs to be addressed, but hopefully the surgeries, people can recover sexual function after the surgeries as well. Now, the erections I mentioned, but I just want to address the difference between, just broadly speaking, sexual function and erectile dysfunction. I think sexual function dysfunction, a lot of it comes down to just the psychological more traumas of going through all this, and I think that's very important to address and try to help patients overcome in whatever ways. But I just to make that distinction, that's all.
Okay, thank you for that answer there. I don't see any other questions in the chat box. Was there anybody else who wanted to unmute themselves and ask a question to Dr. Flechner?
Just thank you for all the time you put into making this presentation. We really appreciate the information.
I'm very grateful. Thank you very much, and it's my pleasure.
Thank you very much. It was very informative.
Thank you so much, Dr. Flechner. I know you're a busy guy, and we appreciate you not only being on our professional advisory board, but also coming here tonight to educate all of us on bladder cancer. So thank you. We're grateful.
Oh, thank you, and have a good evening all.